Hi, I'm Dr. Jose Pereira. I'm a palliative care physician and professor and director of the Division of Palliative Care in the Department of Family Medicine at McMaster University. I'm also co-founder and scientific officer of Pallium Canada. It is important to understand what palliative care is, as many people don't really know it well. There is a lot of fear and anxiety about serious illnesses, death and dying. As a result, we often don't speak about these things, and we often, unfortunately, associate palliative care only with death and dying. The World Health Organization defines palliative care as an approach that improves the quality of life of patients and their families facing the problem associated with life-threatening illness through the prevention and relief of suffering. Palliative care sees dying as a normal process of life. It neither seeks to hasten death or to inappropriately postpone death. This is an important definition given the realities and confusion around euthanasia and assisted suicide, which is legalized in Canada and referred to as medical assistance in dying, or MAID. Most national and international organizations like the World Health Organization, the World Medical Association, and the Canadian Hospice Palliative Care Association do not view MAID as part of palliative care, but others in Canada and abroad do. Stopping dialysis or stopping chemotherapy when these treatments are not effective and are futile is not MAID or euthanasia, but rather good end-of-life care for most people. So, let's explore what palliative care is and what it is not. First, contrary to what many people think, palliative care is not only for persons who are at the end of life. In the last days or weeks, palliative care should begin much earlier in the illness. At the very least, it should be started as soon as it appears that a cure is not possible. Imagine, for example, if you were diagnosed recently with cancer and doctors felt that although it is not curable, there is chemotherapy or radiotherapy treatments that could control the disease. Many people in these situations are experiencing pain and other symptoms, including possible worry and fear. These have a negative impact on quality of life, in addition to pain and other symptoms. Palliative care can help control these so that you can live better while on the treatments. In fact, there's a lot of research showing that people who receive palliative care early, alongside treatments to control these diseases like cancer, heart, lung, and kidney diseases, and neurological diseases like dementia, do much better in terms of quality of life if they receive palliative care early. Unfortunately for some people, the disease cannot be cured or controlled. Despite treatments, it progresses, sometimes slowly over many months or years, and sometimes more rapidly over weeks and months. The evolving illness journey is technically sometimes referred to as the illness trajectory. That is what happens along the way in terms of our ability to function, to get on with our daily lives. Clinical experience and research show that there are three main typical journeys or trajectories. The first one is the cancer trajectory. The second one is the trajectory of organ disease like end-stage heart or lung diseases. And the third is the dementia or frailty trajectory. I invite you to review in your take-home packet what each trajectory can look like. Palliative care is relevant for each of these journeys and should be started early, alongside treatments to control the disease. It is important to remember that palliative care is not a hands-off approach to illness, but instead it is active care. It requires hands-on care and treatments. The types of treatments and what treatments one would use or not change along the illness journey. Second, palliative care is not only for the elderly. Many younger people experience serious illnesses, as do babies and children. Palliative care is also not only for people with cancer. While cancer accounts for about 1/3 of deaths in Canada, diseases of the heart, lungs, kidney, and brain, and that includes dementia, account for the majority of the other deaths. And all these people with these illnesses can benefit from palliative care. Third, palliative care is not limited to only controlling pain and other symptoms. It includes seeing the person as a whole person, a person made up not only of a physical body, but also with psychological, social, and spiritual and religious needs. It helps to explore all these dimensions of being human and how they are affected by serious illness. Fourth, palliative care is an approach and not necessarily only a service. When people hear palliative care, they often think of a palliative care doctor or team, or a hospice or a palliative care unit. But the term palliative care actually best refers to a care approach. A family doctor, home care nurse or social worker, or a cancer specialist or nurse, or heart, kidney or lung specialist can also start a palliative care approach while they are treating the diseases. They could say, let's talk about starting a palliative care approach while we treat your disease. In many cases, it means let's improve your quality of life and find out what is important for you while we are treating your disease. When there are problems that are difficult to control, the specialist palliative care team can be asked to help and sometimes even take over the care. And sometimes for difficult cases, one needs to be admitted to a palliative care unit or hospice. In conclusion, palliative care is not delivered only in hospices or palliative care units in hospitals. In fact, palliative care should be available everywhere where patients with serious illnesses find themselves. This includes in hospital wards, hospital outpatient clinics, family health clinics, their homes, and long-term care and nursing homes. In every region of Canada, all healthcare professionals who care for patients with serious illnesses should have good basic training on how to start a palliative care approach. Unfortunately, many healthcare professionals don't have basic palliative care training. This is improving, but we still have a long way to go. There are not enough palliative care specialists in many regions. Some regions don't have palliative care units or hospices. Others don't have palliative care teams in hospitals or in the community to go and see patients in homes. Some don't have hospices. And many long-term care and nursing homes have not been able to adopt yet a palliative care approach. With education, building awareness, and speaking with our elected leaders in Canada, we can build a stronger, more robust, and accessible palliative care system in Canada so that all Canadians have access to palliative care when they need it.